is talk to Lupeika, your network director. And one of the items that the chiefs from last year asked me to do was do a graduate panel. And so I found amazing graduates from all the FM networks who are going to tell you their stories. So we have a range of practice from rural to Central Valley to up in Reading program director corrections and a direct primary care. So without further ado, I think what I'll do is I'll have Dr. Maryal Concepcion introduce herself, give a little bio. If you could tell us what's your undergrad, med school, residency, practice location, and what you do, and then we'll just go from there. So go ahead, Maryal, pick up, be
Thank you so
first.
much. Yeah, thank you so much, Shabby. Hi, everybody. So my name is Maryal Concepcion. I am a UC Davis Aggie for undergrad. I had a BS in anthropology and a BA in evolution, ecology, and biodiversity. And then I went to Creighton for medical school, where I learned the amazing role of a rural family physician. And so I went to the UC Davis branch of training in Modesto, VCME, whatever that stands for now. I can't remember because I graduated over 10 years ago now. So after graduating Modesto, I transitioned to working for Adventist Health in Arnold, California. So if you triangulate Yosemite, South Lake Tahoe, and Sacramento, I'm at 4,000 feet in the forest in between all those three. I was a little shy of 6 years doing full scope family medicine, doing prenatal care, co-managing for deliveries. I stopped delivering after residency. I do not do hospital medicine or emergency medicine. It does not bring me joy. But then I was doing colonoscopies, and eventually I was told by Adventist Health that I needed to see more cattle per hour. And I decided that people are not cattle, and it was untenable to be told by administrators how to practice medicine. And so I left and I opened my own direct primary care practice, Big Trees MD, in September of 2021. So we are celebrating 4 years this month. And then as part of my righteous rage against the absolute travesty that was employment from a corporation, started highlighting the stories of my colleagues who have chosen to leave insurance-based medicine and work directly for their patients. So I host the top podcast in the nation about direct primary care called My DPC Story, where I have over 300 physicians who have shared their DPC stories, mostly family physicians. And so as a rural family doctor myself, I practice with my fellow rural family doctor, Dr. Jeremiah Philo. He was let go from his Adventist Health position because they went to a non-physician model. So in Calaveras County, we have 45 board certified physicians, the only two of which since 2015, when we moved here, who you can see if you're pregnant, if you need a procedure, et cetera, are my husband and I. So by letting my husband go, Adventist Health denied access to our community to see a physician who they could see if they wish to use their insurance. So it is because I am a physician entrepreneur that I'm able to stay in my rural community, and I'm able to do things like collaborating with public health, doing street medicine, doing vaccine clinics for whoever wants a vaccine clinic, as well as taking care of my own patients and speaking nationally about direct primary care. So in a typical week, I will say that I go into the clinic about 1 day a week. I spend approximately 2 hours with each of my patients. I have patients from just did a circumcision last week to a person who's betting me that if they live to over 100, their care is going to be $1 a month, which is actually 67 cents after stripe fees. I have a very wide range of practice still. I'm able to maintain my skills. I do not do colonoscopies because I was pushed out by the hospital, unfortunately, in that sense. So I stopped in 2019. But I go into the clinic about 1 day a week because I do not code. And so my patients communicate with me via video, telephone, whatever it needs to happen, virtually, probably 80% of the time. And I only go in for the things I need to see, like infections, lacerations, etc. We do not get 24/7 calls because our patients don't have the anxiety of seeing us every 6 to 9 months. And so they know that they can get a hold of us. And we have probably gotten 4 calls after hours. And the way that we're compensated is we work directly for our patients. And so if you calculate that on average, your patient pays you $100 per member per month, and you multiply that times the number of patients, corporate practice typically has 72% overhead. It can be a lot less when you're just doing things transparently. And so our patients all currently have insurance. Some of them have been uninsured historically, but we service Medicaid, Medi-Cal in our state. We service Medicare, we service everybody because we don't discriminate based on what insurance a person does or does not have. And going forward, direct primary care now can be paid by HSA dollars, a part of lobbying that I was a part of in Washington, D.C. And we are definitely highlighting the fact that insurance-based healthcare is not healthcare, is the only option in which it exists. I will loudly and proudly be talking to anybody and everybody about direct primary care because I do feel that when most of our residents go into employed positions and they do not know about physician entrepreneurship, what's going to happen when FQHCs close? R2 FQHC and FQHC Light clinics locally, they're going to close. In rural America, especially, we're going to be impacted. And so by maintaining your family medicine skills, by maintaining full scope practice availability and accessibility to your patients and for an affordable rate. So one visit to the emergency room costs my real estate agent $1,800. That's more than what she pays me to take care of her. And she can text, call me, whatever during the year. So I absolutely stand for physician-led independent practice. And that's what I'm proud to speak on today.
Thank you. Thank you. Thank you. And she does have an amazing podcast that if you have Spotify, I was able to listen to that on my plane flight home. So thank you, Maryal. So Dr. Amanda Mooneyham, go ahead next.
Good morning, everyone. My name is Dr. Mooneyham. I'm a graduate of the Shasta Community Health Center program in the 3rd class under Dr. Lupeika, who is my former program director. And I'm so excited to see everybody on the panel here today. And an advisor to Dr. Hans, and I met Maryal through CAFP. So it is one big family here, with family medicine in California. So anyways, I am one of those that stayed on as faculty and became APD and then program director at the same program which I was trained. My origin story actually starts in public health when I used to work at the coroner's office here in Shasta County, and healthcare becomes really upfront and personal when you can see what's basically killing everyone, right? So in our area, we had many suicides and drug overdose, astoundingly high. I mean, it was pretty routine to have one every day, which is really just a tragedy for how small our community is. I, had seen friends and families that had come through the coroner's office. So that's really what inspired my journey into medicine. Eventually, I liked every single specialty that I rotated in 3rd year and settled on family medicine. I'm sure you guys have the same experience too, but I never let go of wanting to make an impact on mental health and addiction in our area. Like Maria, I'm also do full scope care with prenatal care and deliveries in the hospital. It's one of the things that just brings me joy in my day. The last patient I saw was someone who's 39 and 5, so she's getting ready to deliver some point soon. So I'm really excited about that. I wear a lot of hats, I think, out of necessity for where I work, which is an FQHC. There's a lot of uncertainty ahead, like what Mario mentioned, with changes in legislation, and it really brings out all of our efforts for advocacy. And luckily, my workplace supports all of our advocacy efforts with Lobby Day and resolution writing and all of that. And I'm actually really excited to hear some of the impact that we can make for our area.
All right. Thanks, Amanda. And thanks for carrying on the baton after I left. So Dr. Landin Hegge, can you tell us your story, please?
Yeah, my name's Landin Hegge. I was born in a motor vehicle in Modoc County. So on my birth certificate, it says that. I returned home to practice medicine here. I got my bachelor's degree in health science from Brigham Young University in Idaho. And then I went out to Virginia and got accepted to medical school at Liberty University College of Osteopathic Medicine. They really focused on community medicine and rural areas. And because I grew up on a cattle ranch out here, I really wanted to come back here. I just had to find a way to convince my wife that Alturas was a cool place. I did residency at Shasta Community Health Center. Dr. Lupeika was my program director as well. I really enjoyed my experience there. And one of the reasons why I wanted to go there was because I knew I could get full spectrum family medicine. So my practice up here in Modoc County, we're at Modoc Medical Center. It's a critical access hospital. and it has a clinic and a skilled nursing facility attached to it. So I work out here as a hospitalist. I take a call from 8 a.m. to 6 p.m. during my 5 or 7 day shift. And then I work part-time in the clinic, which is 8 a.m. to 4:30 p.m. I'm expected to see 12 to 16 patients a day. And then we have a lot of mid-level clinicians. I oversee 2 of them and I review their notes and provide education and training for them. I take care of 12 patients in our skilled nursing facility. We have a 50-bed skilled nursing facility, and we just finished building a new skilled nursing facility that's going to open up this next month. The federal CMS is going to let us keep our old facility open, so we're going to expand our beds to 84. So there's a lot of concern about rural hospitals and clinics. And I will say that we don't have that concern here because we have a skilled nursing facility that allows us to fund every other aspect of our healthcare system here in Modoc County. And we also have a healthcare district tax. So every year they raise about $2 million from the tax on the residents, any landowners here in Modoc County that the people voted for, which is actually a big blessing, and it allows us to expand our services. I am director of our wound care clinic, so I do wound care and debridement. I do lots of hospital-based procedures because I'm the hospitalist for our 12-bed critical access hospital when I'm on. I do prenatal care and postpartum care. I team up with OBGYNs in Redding, California, Klamath Falls, Oregon, Susanville, so that if people can't really get a ride, we'll still see them for their prenatal care up through the 3rd trimester as long as they're not complicated. And I really, really enjoy that. I enjoy the broad scope of practice, that I can use all the skills I learned in medicine. And the best part about my job is that I work 195 days a year, and the rest of the time I just have scheduled off. So they really, really want me to stay in rural America. Glad to be here.
Thank you, Landon. Yeah, I'm always amazed what a wonderful schedule that sounds like. So yeah. So Dr. David Araiza, can you introduce yourself, please?
Yeah, David Araiza. So I guess I'll start with the undergrad. I'm from Stockton, and so I went to my undergrad at San Joaquin Delta College, the community college here in Stockton. Then transferred to UC Merced. I know I always wanted to stay local, so I went to UC Merced. I got a biological sciences degree. A lot of time working in between there, doing other things, different jobs. But I finally got into med school, and I was actually a graduate of UC Davis in 2020. I was part of the San Joaquin Valley Prime track. Now I think the closest thing we have there at UC Davis is the REACH program. So extremely proud. That's exactly the program that I wanted. Like I said, I always wanted to stay local. So that program at that time, actually we spent our first 2 years there up at UC Davis, and then we did the next 2 years, or at least I chose to do the next 2 years down in Fresno, which is a community very much like here in Stockton. To me, I always tell people it's a bigger Stockton. It's hotter, but it's essentially the same population that I deal with here. So feel very fortunate to have trained down there. And then I went to residency at San Joaquin General Hospital here in French Camp, which is essentially Stockton. It's right, it's 5 minutes outside of the city limits. And so once again, my whole goal coming into medical school was to serve, train. We always talk about underserved. We always talk about this particular population and a return here. And that's what I'm now doing. I'm at community medical centers here in Stockton, and they serve a majority. I think they probably serve a majority of the Medi-Cal patients here in San Joaquin County. So right now, I actually work in several different locations and do a lot for them. And I think I'll go into a little bit more about how I think my training helped me do that. But right now on my Mondays, I work at the homeless shelter at St. Mary's Homeless Shelter here in Stockton. Tuesdays, I actually, I'm an attending, I do precepting for the St. Joseph's Family Medicine Residency Program. So I do 1 full day there at our Channel location. Wednesdays, I'm at actually a converted house in Southside Stockton that is close to a recuperative / substance use center. So that's a community clinic in South Stockton. And then Thursday and Friday, where I'm at today, is actually our substance use center. Very unique center where we treat not only outpatient, but like this morning, for example, I was actually kind of called it an admission. we admit people to our residential center. We have like about a 12-bed residential center here where I can take someone in, and as long as they're not an acuity level where they need a hospital, but they do want to kind of a monitor detox is kind of what we call it here. I will admit to that, make sure, go over their medications, go over their chronic health conditions, and can review all that. And then if they, whatever they need, whether it be Suboxone, naltrexone, anything to help get over any type of chronic substance use, I can get them set up and honestly try to get them set up for success long-term. We're a short-term 2 to 4 week residential program here, but we connect them with longer-term sober living environments. So I think in general, this is exactly what I wanted to do. I remember when I was at UC Davis, one of the faculty members saying it's always good to look back once you're an attending years later and look back at your personal statement, and are you doing what you set out to do? And I can definitely say I am. It's stressful in its own. I think some of the bureaucracies, even on the FQHC and small organizational level, are a little bit more frustrating than I would have hoped, but treating patients does not burn me out at all. I think this is where I was meant to be, and I'm fulfilling everything that I always wanted to do. So I'm very happy with that. And one thing I would just add, I'm also helping out with UC Davis students, some of the REACH students that are also from Stockton. I'm trying to get them that experience. When I was a medical student, I didn't get a chance to get that community-based type of, in Fresno I did, but when we were up at Davis in our first and second years, we got to team up with Kaiser, which I'm glad they took us, but Kaiser is not an FQHC, right? Kaiser is not serving the same population in general that we're doing here. So I actually have UC Davis students working with me now that are actually from the area that want to return. So I'm really happy to see that I'm able to take them on. So yeah, love what I'm doing. It's tough, but I'm really actually am proud that I'm hearing that everyone is doing as broad a scope as from it that I'm hearing right now. So I'm really proud of my fellow graduates. Yeah.
Yeah, thank you, David. And thank you for taking students. That's my other hat. I appreciate that. So, yeah, I think our last panelist is Dr. Madhupreet Hans. So if you could introduce yourself.
Like Dr. Lupeika said, I'm Madhupreet Hans. I graduated from Shasta Community Health Center. Before that, I did undergrad at UC Berkeley. I was a history major. I got a BA in history. Then went, I think I took a gap year. Sorry, it's so long ago. And then I went to the Alabama College of Osteopathic Medicine, ACOM, graduated in 2018. And then started residency at Shasta Community Health Center. Dr. Lupeika was my program director. Dr. Mooneyham was my advisor, and Landin Hegge was a couple years behind me. So had the pleasure of working with him too. Immediately after residency, I took a spot with a family medicine clinic at Sutter in Roseville. So I was in like the greater Sacramento area. And one thing about Shasta Community Health Center that had drawn me to Shasta Community Health Center was the fact that it was an FQHC. It served the underserved. And that's, I think, what really drew me there. Did a variety of things there. We delivered a lot of babies at Dignity. That continuity of care was something I was very passionate about. In Sacramento at Sutter, I did have the opportunity to continue to follow some OB patients. I had patients on my personal panel that I delivered, followed through their pre and postnatal care as well. I practiced like a pretty broad scope of medicine, except it was for very well-connected insured people up in Roseville. So like Roseville, Granite Bay, Rockland, this area tends to be pretty affluent. So just kind of felt like something was missing. Practiced here for about 2.5, 3 years. And yeah, I mean, kind of like Dr. Concepcion said, I mean, it can be taxing. Caring for the patients is not hard. My big problem was probably the insurance companies. Getting MEGACE denied for somebody who has cancer, right? Like getting really important imaging denied and then waiting on the phone to talk to a pharmacist because that's your peer-to-peer. That was very frustrating. So that was one of the biggest factors for me, to search for something else. I looked at a couple other FQHCs, and then I got offered a telemed position through CDCR, which is the California Department of Corrections and Rehabilitation. It's basically the prison system. So I work at an institution in Corcoran, California, and I provide care to a pretty large yard of inmate patients. They're my patients, and they're 480 on my panel, whereas at Sutter I was seeing my panel was easily 2,500 patients. My patients are sick. My patients are older. Thankfully, I've done a lot of geriatric medicine, so I feel comfortable. But they're people who have sort of been forgotten in the prison system because, in California, thankfully, my patients have more rights than they used to, and they're now exploring their options. They have a lot more allowances than any other state. And so I kind of work with them, provide them with things within reason that can accommodate their health. And I do preventative health care. Every 3 months, we're supposed to go on site. I usually bundle up my patients who need like injections, lesion removals, cryotherapy, biopsies. We do all that at the same time. That's, obviously I'm not doing a lot of baby delivering anymore. That's kind of behind me. But this is very rewarding. I'm working with essentially the underserved who are funded by the state of California, the taxpayer. It's a very rewarding job. I really, really like what I do. And I'm just very comfortable here. So that's basically it in a nutshell. Just to speak a little bit to DPC, I actually worked with a guy who he graduated around the same year as me, came to Sutter, and we worked together for a number of years, and he's leaving to start DPC. And he's a high volume guy, very nice, great guy, but I feel like it's part of our future, if not the future. Yeah, I think it's very, very important to acknowledge that. So I'm excited to see where that goes for him.
Yeah, well, thank you. Well, thanks. So amazing stories. I hope you all heard those. So for the residents who are on, do you guys, this is your opportunity to ask those burning questions. So does anybody have questions? You can either put them in the chat or please just unmute yourself and send them our way. So anybody have questions right now? What was the process like to have a mobile clinic for prenatal care? Amanda?
Yeah, we do have a mobile clinic. Yeah, we do have a mobile clinic, and we have Dr. Patton go out and basically see patients where they are, either on the van or in their encampments, and he brings the focus, like a butterfly focus with them, gets some like rough ultrasound, and does some of the basic prenatal care. They can draw labs if needed, so that's really important as well.
Thank you. Good question. Anyone else want to take that question? Process like that, a mobile clinic for prenatal care?
I would say that my first year I was telemedicine home visit only to keep my overhead low when I was opening. And so I definitely would consider my services the first year to be mobile. It was out of my car and out of a mixture of Amazon purchase things and wholesale ordering things that we can do in DPC, because we can transparently give a person a price of whatever. Included services in our membership would be like POCUS, like I have a butterfly ultrasound, but if a person needed x-rays, blood work, etc., blood work like a CBC is like $3. So we can actually tell a person like your mammogram is $200. That's not related to OB, but when it comes to mobile practice, literally empowering one to just take their knowledge and their ability to say what's normal, what's not normal, what they can handle, what they can't. And, with their physical skills, you can fit all that stuff pretty cheaply and easily into a bag.
Yeah, so Maryal, if you could maybe talk a little more about that, how you can set up, because I know like at Shasta Community, we had a certain, it was a list of these are the labs you can order for a cheaper price if the patient has no insurance or is cash pay. Like how do you set up that process, or where do you go to figure that out?
Yep. Super important question, especially because as we see, even like Quest is trying to sell cash pay labs, right? But I will say that the way to do wholesale medicine is to group up with a GPO. There's a particular set of GPOs that we use. That's a group purchasing organization. We have multiple. It's completely free to join, but collectively as a group, we come together under this GPO to negotiate prices with like national labs like Quest or LabCorp. And so it is through being part of a group. We don't have any membership fees. There's literally nothing other than we're saying we want to come together as this group to use their services of negotiation. We're able to get those price lists like a menu at a restaurant. Modesto Radiology, I have an image. It's literally their clinic manager sent me a restaurant menu of like an MRI without contrast, $465. So even when I went to go get my own mammogram, I had to get a recall. My recall was not covered because that's diagnostic, people. It's not preventative. It was $330. And I said, no, thank you. I'd like to switch to the cash pricing. And so I knew that it was $160 plus an extra 40 for the Tomo. But literally my patients are empowered now to ask me, what is the cash price? When it comes to wholesale medications, I literally go on a wholesale pharmacy and I can shop for, I'm like, if you would like your reflux medicine, you can pay your insurance coverage of $30 a month for your 30 tablets of da-da-da or 30 capsules. Or you could pay $27 for 500 capsules. So that's 2.75 years of the same medicine. So which would you like to do? We are very transparent in our pricing because we have the connections and the ability to, as independent doctors, not have to pay more fees to access these prices for our patients.
Nice. Thank you. And so how do you send a prescription?
So we're actually setting up cash pay, lab access, pharmacy, mail order, as well as in person. And then we're doing vaccine clinics, cash pay, as well as insurance. And so we're preparing for us to be the only access point for our entire community up the Highway 4 corridor. And the way that we're setting up access to medications right now is a patient just says, hey, I need to refill da-da-da. And we say, would you like to use your insurance or cash? And if they want to do cash, we give them a quote. We order it just for the patients who are needing those medications. And if they wish to use their insurance, then we just send the order to the pharmacy. But if a person wishes to buy the medicine through us in the state of California, we can dispense. In other states, you cannot dispense, like Texas currently. And so we're able to get basically medications through our medical license, and then we just do our inventory and we dispense directly to the patient.
Nice. So Amanda put a message in the chat. Is that GPO also for equipment, supplies? What about IUDs? How do you get vaccines? And they're so expensive. So
I will say that this is good for everybody to know, just because of other ways to work the system in whatever we're going to have in the future. So I will say that a GPO can be very helpful to get reduced prices on, autoclavable things, single laceration kits, whatever. Like I needed a gyne dilator and I didn't have one. So my GPO allowed me to access a cheaper price through McKesson or Henry Schein. The thing that I would be concerned about with employed contracts is if your employer allows you to participate in a GPO. There are some contracts out there for the residents to know that allow you to not even own your own social media platforms. So definitely taking your contracts to a healthcare lawyer is not enough, in my opinion. You need a small business attorney to look at your contracts. And the only thing that the CAFP offers is a healthcare attorney, which I have never found to be equivalent to a small business attorney. When it comes to IUDs, we actually have ordered our Paraguards by writing a prescription and sending it to Canada, because for $200, it's now $400. We're very transparent with our patients to say, like, look, this is not an FDA approved thing, but like, this is literally the same thing. It's just a little bit delivery device difference, but your choice, your body. So we're able to get IUDs. When it comes to Mirena, the price is not that different through a group. It's about $1,300. So I will talk with a patient, like, can you go to your insurance doctor just to get these heavy, like high price things that I can't get necessarily? Nexplanon and NuvaRing, I have no problem sending to special order pharmacy, and then I get the device and I insert them or direct the patient. When it comes to things like Abrivso, I order it through their insurance. The COVID grants that we got, I bought a vaccine cooler that is transportable and can keep vaccines from 2 to 8 degrees for 3 days for about $800. And so I go and I haul my butt to CVS, pick the vaccines up, and then bring them back to the clinic and vaccinate them, and it gets billed to their insurance. So I think that is all the questions there, but excellent questions. And yes, it's like when the fires hit Southern California and when CAFP had their like crash cart, I'm like, if I was an employed doctor reading that, I wouldn't know where to go to order lidocaine, where to go to order da. I am very much of, we need to know these things, even if we're not doing DPC directly, so that we can get our patients access when it's denied by the government.
Yeah, no, thank you. Now, just when you mentioned lidocaine, I remember the lidocaine shortage for so long. We had no lidocaine. And that was very, very frustrating trying to, do procedures. So just on that note, so David, maybe could you speak about, because you work with a lot of the homeless population and substance use, like how that all works at your clinic?
Yeah, no, I came into it when, in all honesty, there was already a set up kind of homeless healthcare network here with CMC, but it was it had lost its leadership, being spread kind of thin. At the first couple of years I was here, it's now been 2 years since I left residency. It's kind of tough getting it on track, but I have now a little bit more admin time where I'm trying to focus it into being more integrated, because I think that's what it is, right? When we have anyone off the street, because it's a big part of what I see at all my sites, or someone who is either some type of housing instability, if not all out homeless, but the substance use, right? The mental health. I think going back to all the training I got, I think when someone comes in, I don't need to say, hey, you need to go see someone for that. You need to see someone else for this. Like I can do all that and do it effectively, right? If they really higher level of care, I recognize that, and I'm going to get you help. But they do have it in place, and like I said, I'm trying to grow it and make it more integrated between all our services, and trying to help the organization itself understand that. I think they were barely getting over that, but a lot of the times they were also within CMC even kind of siloing people off. Like, that's a behavioral health issue. They need to see this individual. Well, this is a substance use individual, right? So even within one organization, someone is seeing 3 or 4 different people. They have lost a plan. They don't know what's going on. So I think we're really trying to do, like I said, putting it all under one umbrella. And also what I came in wanting to do is bridge our organization with public health, right? With the county public health. I think I've seen certain counties do it very well. I think Fresno was better at it. I know about the Bay Area counties, San Francisco, Oakland. Some of those public health counties work very well with their FQHCs by talking to other providers and things like that. We do not do a good job here in San Joaquin County. That's just the flat out truth. Me being here for this many years, working with the county hospital and now with a different organization, everyone is kind of siloed doing their own thing. And that's been very frustrating for me. But once again, I'm happy I'm here, because what they need someone to kind of step up and say, hey, let's bring all these individuals together, St. Mary's, the homeless shelters, public health, and let's all work together. So that is a big focus on what I'm trying to do right now, is to get all these individuals at the table so we can work together to be a lot more effective at what we're doing. And right now we have a couple different things. We have a county van that goes out and responds to people in crisis, the medical crisis response team, MCRT, that actually partnered with county, got dollars from the state and from the county to do that. So they're not only available to us, they're available to the entire county, when sometimes they might get a call for police, but police, it may not be something where police need to intervene, right? They may need someone with a mental health issue where you have a therapist, a social worker, someone else that is more someone that's more qualified to handle that type of situation, not just someone with a gun, right? So we have that team, as well as our care link is what we call it, our homeless healthcare team that actually goes out to different sites. But one of the biggest issues we're facing right now, we just don't have enough providers, period, right? Very few physicians, and then even what they're trying to say, we're trying to fill it in with mid-levels. There's not even enough mid-levels to fill it up, or even qualified ones at that. So we're hurting. We're hurting there, and that's why I said I want to be part of the teaching of not only residents but medical students, because I need to bring them back. I need help. So
There you go. Thanks, David. Yeah, so there's a plea to all you residents. I think there is an important thing to know. There are a lot of places you all can find jobs, so don't get super worried about, oh, I'm not gonna be able to find a job. You've heard stories. Sometimes your first job is not necessarily where you stay. So lots of need out there. So, hey, Amanda, just because you're at FQHC in Reading, if you could talk about a little bit about the services, just like David did.
Yeah. So like most FQHCs, we're also considered like patient-centered medical home, which means we offer more than just medical services. So like we have behavioral health, we have dental, and multi-specialty as well. So like pediatrics, OB, psychiatry, family medicine, and then we try to be like a one-stop shop for our patients and whatever the community needs. Like we don't have everything, but we have enough. One of the things that one thing to think about is loan repayment options for FQHC. There's a lot of really great national and state loan repayment options for working at an FQHC. Each one of them is scored with a specific HPSA score, so that's a health professional shortage area. And our Shasta community is pretty high. It's 17, and I'm sure it's even higher in Modoc County, where Landin is. And I know I love working with my patients here. I've known them for over 10 years now, and there's a sweet spot no matter where you work. Once you get to know them after like 2 or 3 years, it's fun because you get to know their personalities, their families, their everything. And that's my favorite part in family medicine, is that bonding with the patients. It doesn't happen in the first 6 months. Like that's the roughest part of starting a new job, is getting to know your panel and understanding your patient's needs or wants, desires, hopes and dreams and all that. Other things with an FQHC, we are productivity and value driven, and we have value-based care, which means we're trying to meet quality metrics. So probably some of the downsides of working at an FQ is that feeling of trying to see as many patients as you can, and making sure that you're getting all the quality metrics in. So that would probably be the 2 drawbacks of working in a large practice, like an FQ or a corporate practice is the same way. But I do keep my patients near and dear to my heart, because I know that they need me, and I can help with what they need on the side. So anyway, yeah.
No, thank you, Amanda. That's good. That kind of dovetails. And if any of the residents have questions, please raise your hand, unmute, put it in the chat. Otherwise, we'll just kind of keep going with it. So Landin, do you want to talk about some of the resources in rural, and what Amanda just talked about, some of the upsides and downsides of working in rural?
Yeah. Yeah. So,
and loan repayment.
Yeah, loan repayment. Yeah. I wish I had my medical school on a full ride scholarship, but I did not. I doubt that most of us ever did that. I read recently, unrelated, that there was a student in Minnesota who got a full ride scholarship for wanting to do rural medicine. So I was like, man, can we do that retroactively? Loan repayment in rural America, you got state and federal. Federal's in flux right now. California has some pretty good state loan repayment programs that are available to most primary care physicians. I applied for a bunch of them. Last year, I got one for $50,000 over 2 years, and then I'm going to keep applying to that. My plan is to not pay back my own loans. So I want loan repayment to do that. So some of the challenges of rural healthcare are also some of the positives of it. I am it. No, there are in the clinic 3 doctors. My patient panel for part-time clinic is 520. So that's part-time. So I do feel like I need to cut back a little bit to have more time with the patients, but with my schedule, I can fit people in at any time, and I feel like I know most of my patients. A lot of the patients here in Modoc County are partnership or Medicare, and as such, a lot of them are on disability and don't have rides. The nearest specialists are an hour and a half away. That would be for OB care in California. It's a place called Susanville. If we want someone who has partnership to deliver at a hospital that has a NICU, that's 2 hours and 20 minutes away in Redding, California. We don't do deliveries on the hospital side. In the ER, we have a great group of docs from Ventura who did their family medicine residencies there, who deliver about 5 babies a year, generally, for people who come in emergently. So that's always fun for them. It is really hard to get people into specialty care. The nearest pediatric specialists are typically UC Davis, and that's a 5.5-hour drive for patients and parents who don't have a car. So I'm really grateful that they have started their telehealth programs. It really helps. I'm managing some of the most complex patients I've ever seen in my life here in Modoc County. And I'm managing pain following oral cancer radiation because they can't go see a pain specialist. Their oncologist is 3 hours away. Their oncologist gave me their cell phone number, which is nice, but I'm the one seeing the patient. So like there's positives and negatives to that. Like some days I feel really great. I helped people today. Other days I'm like, man, I wish I was a computer in my brain because I just don't know everything that I need to know. But I enjoy that. Like growing up on a cattle ranch, you come across things you don't know how to do every day and you figure it out. Here, it's very similar. I have friends I can reach out to, infectious disease doctors I worked with, and other specialists I worked with that I can reach out to. And they told me, like, they knew that I was coming up here to Modoc County, and they said, anything you need, you let me know. So it's really nice. I had a patient who had a partial amputation of their finger tip. They had no idea what to do. They said that it was going to take 4 months to get into the specialist. So I texted somebody and got them in the next day, which was nice, right? So I love the work-life balance. Because I'm rural, I could ask for the moon. Okay. So when I say ask for the moon, I could say I want to work 195 days a year and I want to have at least 1 week off each month, preferably 14 weeks off each year, in addition to paid time off that I can do, in addition to CME stuff. And so I asked for it and I got it because they're desperate for help. Every place needs more help. We need more doctors up here. But they're glad for whatever help they can. And I will say working for a small critical access hospital is completely different than working for a larger system. I'm not just a cog in the wheel. I started the wound care program because I was interested in it. I love point of care ultrasound. And I asked them, I said, hey, will you guys buy me a butterfly so we can do point of care ultrasound? They said yes. It took them 2 days. So we can implement changes rapidly. Love that. But sometimes you do feel like you are isolated, like you feel like you're in the middle of Alaska and you have no help. So if people are really sick, they always have to take a helicopter to Reno, typically is where they go. But that's kind of what life is like. I really enjoy it. I'm coaching soccer right now, so I have time to do that for 10 and 11-year-olds. It's a great life.
Thanks. Yeah, no, thank you, Landon. That's awesome. So I just want to just throw some stuff that was put in the chat. I think, like Maryal said, great advice, Landon, about ask for it before you sign that contract, because it is definitely a lot harder to get it after you've signed and you've showed up. You're like, hey, I'd like to do this. And they're like, yeah, no, it's not in your contract. So I think that's huge advice. So thank you for putting that out there. And Maryal had said the random fact about panels. So Landon was just saying his panel is about 500 DPC, but that's part-time. DPC is like 600 to 800. And, I'm not sure, Amanda, what's your panel? Or David, what's your panel?
I don't know the official number, but I'm sure it's in the thousands, right? It's definitely higher than that. And
Okay.
it's still growing.
Yeah.
So they still calculate ours about 300 per day of clinic. So since I'm 3 half days, then I'm roughly 200 on my panels, which is pretty great, but I'm also
Yeah.
doing a lot of administrative work too.
Yeah. So Madhu, what was your panel again? You have the whole yard, right? Is Madhu? I think she just froze. Oh, what's your panel?
My panel size, I think I mentioned earlier, 480. My whole yard is
Okay.
double that. But yeah, I mean, my guys are sicker than most. I will say I have a larger yard than most physicians that work with me, and they are sicker. So, but it's really not that. It's not unmanageable. It's actually quite doable.
Quite good. Okay. And I'm going to ask you what your pros and cons to working in corrections is, because I know there's a lot of interest in corrections, but I just want to make some acknowledgments to the chat. So, David, you got the Cal Healthcare loans, which is a pretty darn good loan. If you work in an underserved area, it's like 300,000. And Maryal put out their IHS, Indian Health Service, also has some tuition. And again, I would encourage you all to listen to her podcast because it's amazing, and that there are some referral areas to help with rural medicine. So, Madhu, yeah, what's your pros and cons to working in corrections?
I would say right off the bat, the pros are more time with your patients, better work-life balance. Because if you find yourself constantly married to, for instance, my phone had Epic on it. So what do people do? They message you when they want to get in touch with you, and you're just constantly at someone's beck and call. I recall going on vacation the first 6 months after starting there, and I spent the whole time on the phone with a patient who needed a liver transplant. It's just, it wasn't very, needless to say, I was very stressed when I got home. But it's made my life a lot easier with 2 young kids. It's made, I can drop off my daughter in the morning if I have to, I can pick her up after school. All of that has become a lot more, as a mom, it's just something you really want to be there for because those years are short. And when it comes to other pros, I deal a lot with MAT management. So we do a lot of Suboxone. I kind of feel like that sort of that married with the ability to spend more time with your patients, have more one-on-one time with them, it really helps develop that relationship with the patient. And you get, not that I wasn't getting this in my primary care setting, but I was getting less of it. But I feel like I have a very good relationship, very good rapport with my patients. Downsides, it's not an insurance-based system, which is fantastic. But it still is, it's a budget. And what, California is, when there's a deficit, it's like slash. So you're kind of at the mercy of what they choose to keep and what they choose to get rid of. Things, amenities for the patients that they might think, okay, this is all, wasteful. We're going to cut this, like no shoes, even some things like everything sort of, you can't even do like nail files for patients. The mattresses don't have springs in them for obvious reasons. I guess they use them as weapons. And so, just getting little things for people can be sometimes a monumental task. But overall, it's like I said, it's rewarding. You get to do, if your patient needs the care, they get the care. And the kind of the downside to living in such a populated state is that when you put in a referral request, the referral is 100% going to go through the orthopedic surgeon, the oncologist, the pulmonologist. They're going to see your patient. But like everywhere else, that wait could be 6 to 9 months at times. And thankfully, we are able to make patients, get seen within a 90-day period. So I think that's a pro, but oftentimes you can see like a very lengthy wait in a patient's management. So from start to finish, everything taking up to 90 days, it can take a year to get a hip replacement because they have to do imaging. That could take 90 days. Try physical therapy. That could take 90 days. Get an MRI because the specialist wants it, 90 days. See the specialist, 90 days. See the specialist again for pre-op, and then, so on and so forth. So that can take time. So that's definitely a disadvantage of the program.
Yeah, thank you. So don't have much time. You guys are amazing. I'm glad we're recording this. So We got like 5 minutes left, so I would just ask if each one of you could just give like a minute or so of just any sort of advice you'd like to tell our residents, either on loan repayment or finding a job or electives or residency. So just what are your words of advice? So Maryal, we'll start with you.
Yeah, I would say, like Dr. Hans is mentioning, she has 2 young kids. We have a 4 and a 7-year-old. My thing is that time in general, our health, our kids being young, it's all fleeting. And so what I would encourage everybody to do is talk with the people like us who have graduated years out and see like what types of things do we think about now that we didn't think about when we applied to our first jobs. I wanted to have a family, but I didn't have kids when I graduated in 2015. So it's like planning for the future is what I would encourage everybody to do, because when you figure out what your ideal life is, and it could definitely change, but when you figure out what your ideal life is, it becomes clear to you what's acceptable and what's not acceptable to you when you're looking for jobs.
Yeah, perfect. No, thank you. Huge advice. David, what's your words of advice? Thank you, America.
Yeah, similar. I think I'm spread a little bit thin. I think we all get spread thin because we're able to do so much, right? That goes hand in hand with our training being family medicine. But I will say that's what I also love to do, right? If I was at a desk every single day in the same spot, same location, just being as much as I love primary care, 8 to 5, 4 or 5 days a week in one location, that would drive me crazy. So I'm glad that this location I'm at was able to mold all the things I love to do, being somewhere different, teaching, helping out in the street, right? So I think we are in demand, right? That's why I said we're in shortage and we're also in demand. So anyone going in looking for a job, you have all the leverage, right? Get a job that will fit you, fit your lifestyle so that you won't burn out, because I think we all have the passion to do a lot of this work, but have the job match your lifestyle, because it'll be there and you can get it, most definitely.
Yeah, no, that's perfect. Thank you, David. Landon.
Ditto what everybody said already. And then I have a lot of med students and residents come up here. And I think we all go through periods. I still do, where I have the imposter syndrome. I'm like, did I really do residency? I don't remember anything. You really do trust the training you have and trust how to research, right? That's the big thing about what we learned. We learned how to be investigators and detectives, and we learned how to be innovators in our field of medicine. So just trust the training, and most importantly, try to find a job where you can have joy in life. Youth is fleeting, and when you treat older patients in a skilled nursing facility, you see how fleeting it is. And you see how important relationships are. And so to have that good work-life balance, find a great job, open your own practice, do direct primary care, do something that will make you happy, and your happiness will then infect those around you, and it will help your patient's health.
Perfect. Thank you, Landon. Yeah, open evidence AI. I love that resource. If you don't use it, it's great. Madhu, words of wisdom.
I think the biggest advice I can give is that graduating from residency, you know a lot, but you don't know everything, right? And so, yes, having that imposter syndrome, very real. But the minute you kind of you take charge and you have your own patient panel, you will feel a sense of independence. And sometimes your first job is not the right one, and you'll figure that out. It's not like some sort of a long sentence. It's an experience, so take it as such. And sort of in parting, I think someone once told me, like, you just can't pour from an empty cup. I tell my patients that all the time. So even in residency, definitely when you graduate residency, make sure to fill your cup. Whatever it is that makes you happy, either discover it now or rediscover it. Make sure you fill your cup. It's advice well given, but never taken. So definitely do that.
So true. No, I get you. Yeah, that's important. Thanks, Madhu. Amanda, last words of advice.
I have three things. One, get disability insurance when it's cheap, your own occupation insurance. Number two is, like everybody says, make sure that you're planning for your time health and your mental health when you are putting together your career. And then the last thing is don't forget about advocacy. I mean, this is where you can support yourself, support others, and do right by your patients and your communities. And it's such a fun journey to be a part of.
Thank you. Thank you. Oh my gosh. You guys are amazing. You just totally inspired me. And thank you for doing all you do. So it's just so heartwarming to hear what everybody's doing in family medicine and in the network, outside of the network. Lots of great stuff here, good advice. And thank you all for taking the time to, tell us your stories. We appreciate that. So thank you very much. Have a good rest of your day.